Okay. I'd like to start by acknowledging the traditional custodians of the land on which we gather today and pay my respects to the elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. A little bit of housekeeping, just quickly. So there's coffee and tea facilities here. We won't sort of have a break until lunchtime. The restrooms are just there behind you through the glass smoke doors. Hopefully keep things pretty quick and moving along today. So the first person I'd like to introduce is Associate Professor Eng-Siew Koh, who we know very well. She's a radiation oncologist from Liverpool Hospital in Sydney, and she's going to do our opening speech today.
Good morning, everyone. It's such a wonderful pleasure to see you all in person after so long, and it's really wonderful. It's my great honour to be able to open this forum with a few brief words. So look, it's been a long time since we've seen each other, but really when I come to these meetings, I think the patient education forum is the highlight, of the meetings, in the sense that it reminds me as a health professional about our real value and our mission, and the fact that patients and carers are really at the centre of all our efforts. I know we haven't seen each other for a number of years in person, but just to encourage you that there's been tremendous progress in terms of treatment and trials and advances in care, and I'm sure you'll be really interested to hear about that from our speakers today. And I just want to reflect on the fact that when we think about our patients and carers and families, I really see them as partners in that effort. Not just recipients, but true partners in all of that. So I really just want to commend the forum to you today. Congratulations, you made it. Despite all the challenges and the busyness of life, really commend you for putting aside the time today and being here in person. I hope it's a fantastic time to network, not only to learn and to be educated, to be inspired, to hear about practical strategies that you can share, but I think just being together has incredible value. So it's my pleasure to open the forum. I hope you have a fantastic time and look forward to engaging with you throughout the day as well as our series of meetings. Thank you.
Thank you, Dr. Koh. So our first speaker today is Dr. Frank Saran. He's a senior radiation oncologist in New Zealand with more than 2 decades of experience. Dr. Saran's specific interests include innovative new cancer treatment techniques focusing on improving survival while minimising treatment-related side effects. Dr. Saran.
Well, thank you very much for the lovely invitation. I'm very honoured to get out of my little bubble in New Zealand and actually meet people in person again, which is really different compared to the Zoom where you fall asleep and you don't go through the fingernails. All the other things I tend to do when I'm trying not to have to be under the microscope from people watching. I'm very honoured to be here today and talk to you about something that I've experienced. So my main interest has been actually in pediatric and young adult cancers. So I was well as a sidekick. I do some grown-up people as well. As a sidekick, you can't let my children alone. But that's been sort of my main area of interest when I came from Europe about 4 years ago, where I acquired a little bit of experience in this area, which I would like to share with you. And one of the benefits of being at the more mature end of the spectrum, you have a reasonably long distance to look back. Most of you will probably have noticed in life, things go around again, and they get reinvented, and they've been resold and rebranded as the latest thing. But most of these have already been there before, and we've seen them, and it's just trying to put things in a bit of a different perspective. We've made great progress in the management of childhood cancer. Both overall survival and quality of survival has tremendously improved over the 30 years that I'm involved in radiotherapy for children in my profession. So there's a tremendous amount of progress that's made, but a lot of things we still have failed our patients and our families on, but we didn't quite achieve what we wanted to achieve, whatever that may be, sold on paper to you as parents or as caregivers. So what I want to do to give a little bit of an overview of the experience of nearly 30 years of where I come from, where we started off and where we are now today. And some things you will see have made some tremendous improvements, but in the end of the day, we still are limited in the way how we manage children despite all of these improvements, because we still do stuff where I started off. So if I could, that was a bit like hot. Can't see exactly what I'm looking at. That is the word. Okay. So what it is that in order to change the future and to understand what needs changing, where are our opportunities, what we can do, we really need to understand where we've been in order to know where we would like to go. When I started my career as a tiny radiation oncologist, I met a lady called Chantal Khalifa. So because I'm European trained and all my links are to Europe, so a lot of people I know very well, maybe not very well known to you, and vice versa. So a lot of people abroad really recognize immediately. One has heard of some of them, but not necessarily in person. Chantal Khalifa was the head of pediatric oncology at Gustav Rossi. That was the centre in Europe for pediatric oncology.
Should you use an example of that proceedings at the moment with ultrasound because of concerns about?
Okay, so we've got multiple sessions at the same time. It will challenge your capacity to compartmentalise. Chantal Khalifa was the procreator of systemic chemotherapies at the time for children, and her specific area of interest was high-dose chemotherapy. I'm sure some of you will remember high-dose chemotherapy was at the time curing every disease under the sun. I've seen people with glioblastomas going through a high-dose chemotherapy with stem cell transplant. Of course, all the breast cancer patients went through high-dose chemotherapy until we learned that it's not the answer to everything else. And when I started in the mid-90s, getting involved in pediatric oncology, I was told I'm a dinosaur. To be honest, I'm dying out in 5 years' time. We cure everything with drug treatments. Radiotherapy is obsolete anyway. Why do we want to invest a career into something that is a dying branch? And see here, nearly 30 years later, I'm still standing here and I'm still as busy as I've been 25 years ago. So I want to talk you through a few things, just an idea, because many of you may or may not know a lot about radiotherapy. Radiotherapy is quite an old technique compared to medical oncology. We're a little bit more mature, we're not as good as the surgeons who date spent hundreds of years, but we've got more than 100 years of history of actually treating cancer with radiation treatment for therapeutic purposes. And again, there's a lot of misunderstanding about radiotherapy. They used it to improve the skin care of the elderly by putting radium cushions on the skin, which made them really nice and red and gave them lovely skin cancers. But at the time, not everyone knew what they were doing, so we learned a lot since then, and we've moved on. But again, our techniques as well, the use of stereotactic radiotherapy is again very old-fashioned technology. It hasn't been invented yesterday, but it's something we've been doing for a long time. So this is where the place where I spent most of my career, which is the hospital called the Royal Marsden Hospital. It claims to be the oldest cancer centre in the world. It was the first dedicated cancer hospital built about 175 years ago and is doing still well today. Again, as you can see, sort of now we've moved on a little bit in the way we provide patient care, and the machines look slightly different, but there's still radiation in the end of the day. The fundamental physics have not changed. So when we talk about childhood cancers or young adult cancers, where's the yeah. Yeah, what's the point of it? Oh, there it is. Okay, we'll go back. So you can see sort of that actually the type of cancers we experience in childhood are different from the ones in the early teens and early 20s. And it changes then over time in adulthood, the carcinomas become the predominant type of disease to be treated. And again, you see that in the incidence of cancer, so in the age of 0 to 14, the incidence of brain tumours is incredibly high, even higher than leukemias and all the other tumours. But if you advance over time, over age, brain tumours become, compared to other cancers, all of a sudden a minority. We know that we understand medulloblastoma from some people who actually identified these tumours as a pathological entity in 1925, so this is not a new finding. Cushing and Bailey were the two pathologists describing medulloblastomas at the time for the first instance, and we generally know them as the little blue round cell tumours in the brain. We still stage them to some degree, something really old-fashioned, dating back to 1969, which is the chance staging. We have lost a little bit about the size because actually in brain tumours, usually size does not matter. It's extremely rare that size matters in brain tumours. To have it is bad enough, and the size rarely matters. So we stage them with no evidence of disease, evidence of cells sealing in around the CSF, the fluid surrounding the brain and spine, or if there's really lumpy disease in other areas, we code them as M2 or M3. However, in the 90s and 2000s, we started to understand that actually all these little blue round cell tumours are not one entity. We developed that molecular assessments of tumours can actually derive different kinds of cancers, and we can actually cluster them in different groups. And this one led actually then to a subclassification of medulloblastomas no longer being just one entity, but at least 4 entities that have different molecular characteristics, as well as slightly different outcomes. And if you look at the incidence over time of these as well, they are quite reasonably specific with heights, with peaks and troughs, depending on the type of brain tumor you have and the grouping. We know that despite everything else after surgery, the mainstay of treatment in order to achieve cure for children is still related to radiotherapy. Radiotherapy is the second most fundamental part of curing children from, or young people with medulloblastoma. And the backbone of this is, as today as it was 30 years ago, is still craniosspinal imaging. So it's a journey through time, so I'll show you where I started. So we started off with things called simulators, which a lot of people in the audience, or young people, had never ever heard of. So these were basically X-rays on which we draw lines to do blocks and make compensators, manual compensators, in order to treat the brain and the spine without knowing any more intricate details, and worked out the dosimetry and strength of treatment on the basis of shapes in the figure of patients. This took quite a long time, until roughly about sort of in the 2000s, early 2000s, we started to find out that you could use a CT scanner in order to identify anatomy and to develop better ways of predicting the dose to patients receiving treatment. So initially we started off, most people actually started off with a probe treatment, which again nowadays hardly anybody ever remembers, but it was at the time a big thing to go from probe to supine because people felt very unsecure to change something that's been in practice for about 40 or 50 years. So we then started to changing patients around and treating from underneath the table, and again we were still using sort of straight line spines, and we're using sort of gaps in order to shift in the junction the radiation dose to make sure that we don't overdose, but as well don't underdose the children in the area that we need to match with. And that again is a skill in its own right. In order to then actually change it from the direct field, which gives quite a lot of intensive radiotherapy, to a large area anterior to the spinal cord, we started off with conventional radiotherapy as a 3D conformal, so the beams were just coming from the back in a straight line, and you can see this is the heart here. A lot of the dose of the radiation went to the heart. Okay, so we tried, you can see the heart there. So, and then we invented something called IMRT or VMAT. And go through that. Can you click on it? I need to. So for those people who are non-radiation oncologists, my apologize to those who are very, very experienced, sort of old heads. So basically intensive modulated radiotherapy, or VMATs, or whatever you call it, and however it is sold, or precision radiotherapy, is basically painting by numbers. So if you're good at painting by numbers, you will become a good radiation oncologist. So the longer the leaves are open on the linen, the darker the area gets, and the more radiation is exposed. And the brighter the colors, the less radiation has been given to this area. And that's basically what we're trying to achieve, that we can modulate and target the radiation much more precisely to where we want it to be. So when you go from a straight line, and this is about the 20 gray isodose line, it's probably easy to see here, you can see that all of a sudden you can conform very nicely to the area where you want to treat it, reduce the dose to the surrounding tissue from the direct field. But always everything comes at a price, nothing comes for free. So by reducing the dose to the heart, you spill it out to other parts of the body, all at a lower range, but you still have to get the dose somewhere into the patient. And this is shown here in this cohort, where you can look at different ways of looking at direct field versus this more conformal arcing technique. You can see that you shift curves to the left, so this means the high doses here are reduced, while at some areas the low doses are increased compared to the two different approaches. So you save a lot of radiation here, but you pay a price to add low dose radiation at the other end. We still have subtle arguments about whether one is better than the other, and that remains totally unresolved, although people have very strong views about that. However, the most conformal technique actually is called the proton radiotherapy, something that is at the moment not yet available in Australasia because of the technical propensity of proton things, which are still radiation, but in a slightly different form. They go in and they have a very steep fall off, and there's not this dirty dose at the end, which is sort of the grey stuff that will just spill out all over the patients. And therefore, as you can see here, you know where you want to stop at the end of the bone, so there's no radiation anterior to the bone at all, compared to photon RT, where you still always have to give a small amount of radiation. So this is, in a way, technically a fairly ideal way of giving radiotherapy, with minimizing the risk of the normal tissues in patients receiving radiation, unnecessary side effects. You are actually extremely lucky in Australia, because actually you got a facility coming online in approximately 2024 in Adelaide with a very sexy new building and a very fancy new machine, which will be able to do these kinds of treatments for patients who truly benefit from it. So well done. So however, the treatment usually for craniospinal for brain tumor patients with medulloblastomas, because they've got a propensity to see through the fluids in and around the brain, is to treat the brain and spine prophylactically, and then focus on the area of the original site of disease, which is the medulloblastomas, the back of the head. This was the very first time of a conformal focal boost to the area of the back of the head, which we do slightly sexier today than we did many, many years ago. So nowadays, when I started, we were actually defining the area that needed treatment, the whole posterior fossa, so it's the whole cerebellum, which is the final motor coordination of your body, as well the entire brain stem, and that would define that as a volume. Again, in the initial day, we put this on a bit of a field on an X-ray and said, this is what needs to be treated. We get a field from the left, a field from the right. Everything got everything, we were definitely certain, but it clearly treated a lot of stuff unnecessarily. And now we've been moving towards an area where we just treat the area of the tumor origin, which is the tumor bed, with a very small safety margin, which, as you can imagine, just looking at the difference in size, reduces dramatically the amount of volume we need to treat, and that in turn should reduce the long-term side effects. There's a very elegant paper from the group of St. Jude's demonstrating the differences about changing the dose overall of the craniospinal axis and the volume from whole posterior fossa to just targeted boost, and the amount of gains you can do in receiving less radiation to the body compared to what we've done in the past. And again, it shows that you can use different techniques. However, the best always comes in the end, comes out basically as protons. Albeit the differential between proton radiotherapy and photon radiotherapy has been shrinking dramatically over the last years as we got better to use the tools we have, which are available everywhere where you live here in Australia and New Zealand. I just want to touch on some of the very pertinent trials that have been done. So again, very old, very few people will remember the original trial that caused all the havoc and all the paradigms around the management of medulloblastomas date back to a time in the sort of early 90s and 80s, where they performed a trial where they offered a standard dose of radiotherapy and no chemotherapy of 36 gray, and compared it to a lower dose because they recognized the side effects caused by the radiotherapy. They wanted to give a lower dose, and they had a much poorer outcome with a lower dose alone. The moment they added and compensated for the difference in radiation dose with drug treatment chemotherapy, you can see that the curves became identical between high-dose radiotherapy and low-dose radiotherapy and chemotherapy, being the yellow line, and the curve with a reduced dose radiotherapy. And this was the name that everyone knows in this area called Pecker. He basically was the lead for the clinical study who showed that actually the outcome can be now excellent, about 5 years, around 85% long-term survival rate for patients who undergo radiotherapy after surgery followed by drug treatment with chemotherapy. In Europe, we have a quite long tradition to run clinical trials with medulloblastomas, actually starting in the 70s. So the first clinical trial was done headed by Diana Tate, a colleague of mine at the Marsden, and then we actually had a time when actually the UK was clinically lead, and then we got lost in transition in the European politics, and all of a sudden everything drifted away more towards Germany and France, and the UK became a little bit more like an appendix, a little bit like, you know, an early Brexit. Okay. What people tend not to present or talk about, actually there has been actually a clinical trial performed in France, which actually is a chemotherapy-free trial. Again, in pediatric oncology, it's nowadays very hard to imagine any child being treated without receiving chemotherapy, full stop. Whether needed or not remains a matter of debate on occasions. But there was a trial where they were using twice-a-day radiotherapy, having very similar outcome to the combined chemoradiotherapy approach with a chemotherapy-free treatment using twice-a-day radiotherapy called hypofractionated radiotherapy, or MSWAP98. The reason that is only relevant because the outcomes were so good that the group tried to actually see whether this will lead to lower risk of long-term side effects. And the outcome was the same with twice-a-day radiotherapy versus once-a-day radiotherapy from a large study group we call PNAT4 that was performed in Europe in the 2000s. But overall, the quality of survival was equally good between those two arms. So there was no real measurable benefit from the twice-a-day radiotherapy, as it's an added burden on both patients and carers. Everything's gone back to once-a-day treatment. Again, we already knew for quite a long time that actually treating the whole posterior fossa may or may not be required. But the Americans didn't believe anything. You know, when you come from America, it's the maximum treatment. The more, the better, because you pay for it. And you pay a lot for it in America. So it's not what the treatment you require, but the treatment you can pay for. So the Americans do not believe what we continuously thought was the right thing to do. So they ran a trial. And they looked at comparing, and that's actually recently been reported in 2021, comparing targeting the posterior fossa in its entirety versus just targeting the tumor bed. And as you can see from the two curves, you will be hard to see any difference. If you see a statistically difference between those two lines, which to me are one line, you've got much better eyes and I need a new pair of glasses. However, what they could demonstrate actually that giving a lower dose of radiation therapy compared to the current 23.4 to an indiscriminate number of patients diagnosed with medulloblastoma that is not molecularly defined does actually lead to poorer outcome, both in event-free survival but as well in overall survival. However, the most problems we have actually that these treatments do cause side effects. They do not come for free, and the side effects are not measured in 2 years or in 3 years or in 5 years as many of the survival curves are. We have to talk about 10, 20, 30, 40 years. And we know that actually nowadays 1 in 700 adults is actually possibly a survivor from a pediatric cancer. So there's a quite large number of people affected by this problem. And again, nearly 2/3 of all patients who become long-term survivor have some chronic health issues. And virtually most of them, all of them in childhood will have hormone problems because the hypothalamus, which controls part of the control, and the pituitary gland are very close to the area where we treat, which is in the middle of the field of the craniospinal axis RT. And it doesn't matter which type you use, you always have to treat those. And we know that the doses required are actually pretty low. So between 18 and 24 gray, you lead to growth hormone deficiency, which means lifelong replacement probably for children with a growth hormone deficiency, which at the moment is still given as a subcutaneous injection. 30 gray plus more to the pituitary gland lead as well to probable multiple endocrine deficits over the years to come. And the same applies to the cognitive outcome. The brain is not mature until about the early 20s. So there's a continuous maturation of the brain ongoing, which is affected by the use of radiotherapy to the brain. And we know that the outcome of these patients is actually still disappointing. So even in reduced dose radiotherapy and in patients who have chemotherapy, there is still a continuous loss of IQ over the years, which is continuously declining, albeit, and there is no plateau, so it continues to get worse over time. Well, there will be somewhere a bottom ceiling somewhere. Well, but we know that sometimes that younger patients are more affected than older patients. What I want you to remember that not all children start with an IQ of 120 when they go into treatment. So some parental expectations is well to be tailored to the starting points of where those children start. So it's a very complicated discussion to have with any parents. However, the last and the most important bit is radiotherapy. The best radiotherapy, in my professional opinion, is no radiotherapy at all, because radiotherapy comes intrinsically with the ability to cause other cancers. And this is particularly relevant in children, where the majority nowadays will become long-term survivors. We know that the use of radiotherapy doubles the incidence rates roughly, probably at 30 years, of having tumours compared to those patients who were treated as oncology patients but did not require radiotherapy. We know as well that the incidence rates, particularly in PNETs, actually can be up to 10% at 30 years for malignant tumours that you're likely to be able to attribute to the treatment received. And this is something we need to be aware of, and these are two of my patients where I personally caused that kind of problem. One is an anaplastic astrocytoma, and one is a meningioma as a consequence of the radiotherapy that I gave these patients at the time of child. There is a perception, and we're still awaiting larger numbers and more decent randomized data to see whether the second malignancy rate can be reduced by the use of proton radiotherapy, because the integral dose to the body is lower regardless of what type of modality of radiotherapy you've been using in conventional terms. So this risk is potentially mediated and reduced by the use of proton RT. However, not all is that simple, because we can't just blame the radiotherapy. Fortunately, we've got a genetic background. Why did these patients get brain tumours in the first instance? Are they potentially prone to have genetic abnormalities that drives other cancers in the years to come? There's a tumour that causes problems. The surgeon is not without fault here, nor is the chemotherapy doctor. But usually whenever you have a problem, it's always the radiotherapy, and I accept everything. Whatever the problem is, it was my fault, and I'm happy to live with that. Because in the end, I think as well, I probably cured the patient as well. So in summary, overall, the management of medulloblastoma has become much more diverse, much more skilled, and much more specific. And again, we're probably looking at some stage in the future that we will as well do have molecular targeting that targets the specific pathways of these patients. However, as of today, it's surgery, radiotherapy, and conventional chemotherapy, as we did more or less 30 years ago. I think we're somewhere at the verge to possibly have some paradigm shift, but as of today, we're still there where I started. However, in the end of the day, the outcome of a patient is not defined by a single person or a single modality. It's part of the team. And your outcome of every patient is only as good as the weakest link in the whole chain of what needs to be treated. And that's where I would like to stop, because I think I've slightly overrun.